My name is Dr. Gregory Stevens, and this is the Osteopathic Approach to Headache and TMJ. I want to thank Dr. Edwards for the use of his slides and content from previous presentations. Objectives for this lecture are to discuss epidemiology of headaches, classification and differential diagnosis of headaches, red flags during physical exam and history taking, how to gather an appropriate headache history, how to perform an appropriate headache physical exam, review of migraine, cluster, and tension headaches, and the role of OMT in headache treatment. Let's talk about epidemiology first. Headaches are one of the most common conditions seen in primary care practice. Approximately 40 to 50 million Americans seek treatment for headaches annually, and 1 in 6 Americans have chronic headaches. 23% of households contain a member with migraine headaches, and the prevalence of migraines is inversely related to household income. That is to say that people of lower socioeconomic status have an increased prevalence of migraine headaches. Migraine-related disability is significant, costing anywhere from 1 to 13 billion in lost productivity per year. What are the pain-sensitive structures within the head that are responsible for headaches? First, there's the venous sinuses and the respiratory sinuses, including the frontal and maxillary sinuses. The intra- and extracranial arteries are pain generators as well, as is the dura, cranial nerves 5, 6, and 7. All the muscles of the head, face, and neck and their associated fascias, eyes, and the skin and its blood supply can all produce pain. Let's start out by differentiating headaches into primary versus secondary headaches. Primary headaches are considered tension headaches, cluster headaches, migraine, and other less frequent headaches such as paroxysmal hemicrania. Other types of primary headaches, albeit less common, are trigeminal neuralgias, primary stabbing headache, primary cough headache, exertional headache, coital headache, hypnic headache, primary thunderclap headache, hemicrania continua, and daily persistent headache. Secondary headaches are attributed to other dysfunctions, such as non-vascular processes, trigeminal or occipital neuralgia, cervicogenic headache, that is to say headaches that are generated from the upper cervical complex, muscle tension, sinus or intracranial infection, visual strain, increased intracranial pressure, myofascial trigger points, trauma, infection, substance or withdrawal from substance such as caffeine, psychiatric disorders, and disorders of homeostasis. Let's talk about the warning signs of serious conditions in patients with headache. These are the quote-unquote red flags. New onset or new type or worsening pattern of existing headache. Worsening or the worst headache ever. Abrupt onset. Headache that is triggered by Valsalva maneuver, cough, or exertion. Headache during pregnancy. New onset headache in a person greater than 50 years old, and headaches associated with focal neurologic signs such as seizures, confusion, impaired alertness, weakness, or papilledema. Also, pain associated with local tenderness, such as of the temporal artery. This may tip you off to temporal arteritis. Headaches in association with systemic illness, such as fever, nuchal rigidity, weight loss, or artery tenderness, and any secondary risk factors such as cancer or new headache in an immunocompromised patient. Next, let's talk about how to take an appropriate headache history. Like we start any history, we begin with onset, palliation and provocation, etc. Regarding onset, we want to know if this is acute. If it is, that may make us think of something like subarachnoid hemorrhage, severe hypertension, carotid or vertebral artery dissection, glaucoma, trauma, etc. Subacute presentation of headaches may lead us down the path toward cerebrovascular ischemia, migraine, or cluster headaches, as well as the other ones listed. Insidious onset may make us think of tumor, substance-induced or withdrawal, tension, or cervicogenic headaches. We also want to establish age of onset. How old was the patient when the patient started? How old was the patient when the headache started? Also, duration and frequency. We'd like to know what makes the headache better and what makes it worse. We'd like to know the quality and location of the headache. Vascular headaches tend to have a pounding type sensation. Tension headaches are often described as squeezing. Tension headaches can also be described as chronic and nagging. We'd like to know, does it localize to extracranial arteries, the sinuses, the teeth, or tendon or muscle attachments? Is the pain distribution unilateral or bilateral? Does the location change? And of course, what is the severity of the headache? Associated factors may include menstruation, activities, position of head or different postural positions, time of day, exercises, sleep habits, food and drink intake, environmental factors, and evidence of anxiety or depression or other psychological illness. Other associated symptoms may include nausea and vomiting, photophobia or phonophobia, auras, neurologic or autonomic dysfunction. Of course, as always, we want to gather the past medical history, surgical history, and dental history. A trauma history can be important as well. Oftentimes, headaches stem from a fall that may have been a long time ago, or even birth trauma. Obtaining a social history and getting information about their occupation, use of alcohol, caffeine, tobacco, and drugs is often quite helpful. A family medical history, having a better understanding of exacerbating and relieving factors, and previous evaluations and treatments and whether or not they may have been successful are all important pieces of information. Other things that may be important in reviewing with a headache history are birth history. For example, a protracted or especially complicated birth may give us information about whether or not there was cephalopelvic improportion. Maternal complications should be reviewed. Length of labor, method of delivery, i.e. was it vaginal, or did complications necessitate a C-section? Was a vacuum or forceps used? And were there any neonatal complications? Also take note of childhood growth and development. Let's talk about the headache physical exam. As always, we'll start with vital signs, mental state. A cranial nerve exam is extremely important in evaluating headaches. Strength in the face, neck, and upper extremities. Sensation in the face, neck, and upper extremities. Reflexes, assessing their coordination, and a detailed musculoskeletal exam. Make sure to observe and palpate the facial and mandibular muscle attachments, including the temporalis, pterygoids, masseters, occipitofrontalis, and buccinator. Anterior and posterior cervical muscles as well, including scalenes, SCMs, traps, and levator scapulae. Palpate the suboccipital muscles, the temporomandibular joints, and assess the cervical and upper thoracic spine, as well as the OA. When evaluating chronic or recurring headaches, a more comprehensive musculoskeletal evaluation may be necessary as well. This could include things like leg length discrepancy, sacral base unleveling, cranial rhythm activity, and cranial suture mobility. Are the symptoms able to be reproduced with palpation or physical exam maneuvers? This may lead us down the path of myofascial pain syndromes, TMJ or dental malocclusion, cervical spine pathology such as spondylosis, degenerative joint or degenerative disc disease. Also, nerve encroachment can cause headaches. Moving on, let's talk about tension headaches. This is the most common headache type. It's more common in women, and it peaks between 20 and 40 years. It's often described as bilateral, with mild to moderate intensity. It's often described as being tight or having a sense of pressure in the forehead, temples, or back of the head and neck. It is usually not associated with nausea or vomiting, nor is it typically exacerbated by exercise or routine physical activity. It's often related to postural imbalances and somatic dysfunction. For example, the upper thoracic spine and the cervical thoracic junction and cranial somatic dysfunction can lead to increased sympathetic tone. Increased sympathetic tone leads to increased muscle tone, vasoconstriction, and facilitation of pain signals. This results in decreased blood flow to muscles of the upper back, neck, and head, and the net effect is increased muscle tenderness and sensitivity to pain. Tension headache may be related to abnormalities in central pain control mechanisms and/or the trigeminal neuronal hypersensitivity. The spinal nucleus of cranial nerve 5 is a major relay station for head and neck pain. It receives pain signals from pericranial muscles and cephalic arteries. It gets intense afferent nociceptive input, which leads to facilitation and sensitization of the entire pain pathway, leading to painful sensitivity to usually non-painful stimuli. With tension headaches, nociceptive input leads to myofascial pain, and non-noxious stimuli can equal muscle contractions. With migraine headaches, nociceptive input may lead to vascular vasoconstriction or vasodilatation. Let's talk about treatment for tension headaches. First, we want to look for and address the underlying causes. As discussed previously, posture or muscle imbalances, somatic dysfunction, trigger points, stress, fatigue, emotional conflict, depression, and anxiety, and very importantly, work ergonomics. Treatment may include exercise prescription and lifestyle modifications such as the addition of yoga or Pilates or any other core strengthening program. Be careful with analgesics and NSAIDs, and be certain to avoid use, particularly chronic use, of opiate pain medication. Often overuse will lead to a worsening cycle of headaches. Consider the use of tricyclics, particularly if sleep disturbance is also a factor. Here's a picture of the tension type headache. Next, let's discuss migraine, the second most common cause of headache. This afflicts 15% of women and 6% of men. Onset is usually in childhood or adolescence, possibly early adulthood. The initial attack, however, may occur at any age. As previously discussed, new onset of headache in a person over 50 is something that needs to be evaluated very cautiously. Migraines often run in families, and they typically have the classic triad of auras, which includes visual scotoma or floaters, or scintillations, which are described as flashing lights. Migraines are typically unilateral and throbbing, and are often accompanied with nausea and vomiting. This is described as the classical migraine. Other types of auras include tinnitus, sensory change in the head, neck, face, or arms, weakness, ataxia, or even dysphagia. Most of the patients do not have visual aura and are therefore referred to as having common migraine headaches. Photo and phonophobia are common in migraine patients. Vertigo may occur. Attacks lasting 4 to 72 hours is typical, and they are often relieved by sleep. There are a variety of triggers for migraine headaches, including foods, beverages, use of hormonal birth control, stress, exercise, hunger, lack of sleep or travel, strong smells, change in barometric pressure, bright lights, or loud sounds. Next, let's talk about the mechanism of pain for migraine headaches. Migraine symptoms are produced by vasoconstriction and vasodilatation. The large innervated adrenergic arteries at the base of the brain respond to catecholamines. The non-innervated arteries in the brain parenchyma respond to local metabolic factors. Vasoconstriction via the adrenergic system leads to decreased cerebral blood flow, and platelet release of serotonin leads to sensitization of pain receptors in the blood vessels. Anoxia and acidosis, secondary to decreased blood flow, leads to dilation of non-innervated vessels, leading to increased cerebral blood flow and local vasomotor changes. Interestingly, the aura portion of the migraine is caused by vasoconstriction of the vessels, and the pain portion of the migraine is caused from vasodilation of vessels. And no, this is not the kind of aura we're talking about. More about the mechanism of migraines, and moving on to the trigeminal vascular reflex, afferent fibers from the cortex, thalamus, hypothalamus, and the upper cervical complex communicate with the spinal nucleus of cranial nerve 5. Impulses travel via cranial nerve 7. Parasympathetic dilatation of the internal and external carotid arteries, and pain perception increased by the feedback effects of vasodilatation into the spinal nucleus of cranial nerve 5. So what's the role of somatic dysfunction with migraine headaches? Upper thoracic somatic dysfunction leads to increased sympathetic tone to the innervated vessels of the head. This may in turn lead to vasoconstriction of the sympathetic innervated vessels, leading to decreased cerebral blood flow, leading to a decreased threshold for cerebral vasodilation and production of migraine symptoms. Cranial somatic dysfunction affecting the cortex, thalamus, hypothalamus, and or upper cervical spine somatic dysfunction cause a transfer of afferent pain stimuli to spinal muscles of the trigeminal nerve, and vasodilation and resultant symptoms via cranial nerve 7. Cranial nerve 5 courses through various portions of the sphenoid bone. Hence, dysfunction in the sphenoid bone, such as a side-bending rotation or torsion, may be a trigger of migraine headaches. Temporal bone dysfunction and sphenoesquamous compression may lead to irritation of cranial nerve 7. And even somatic dysfunction in areas not directly connected to the head, such as the lumbar spine, sacrum, and pelvis, may lead to myofascial strains transmitted to the head and play a role in the genesis of migraines. Therefore, treat the whole patient. So what do we do with our OMT treatment? We'll use this to modify triggers from bony and ligamentous myofascial structures. During an active headache, gentle indirect treatments such as venous and lymphatic drainage will be used. And because of prominent autonomic nervous system involvement, we want to evaluate and treat the sites of sympathetic significance. This includes the lower cervical spine, upper thoracic spine, associated ribs, and myofascial attachments. Also evaluate the joints of the head and neck, muscles, and myofascial restrictions of the head, neck, and shoulder. Medical management of migraine consists of the following. Treatment of an acute attack may consist of simple analgesia with aspirin, Tylenol, and often caffeine is added. This may be combined with an antiemetic such as Zofran. As discussed previously, long-term use of opioid-containing analgesic preparation should be avoided. Severe attacks can be treated with one of the triptans, like sumatriptan. These are potent vasoconstrictors of the extracranial arteries and can be administered orally, sublingually, or by subcutaneous injection or nasal spray. Drugs used for migraine prophylaxis include beta blockers, tricyclics, anticonvulsants, serotonergic drugs, and calcium channel blockers. Here's a picture of migraine headache. Next, let's discuss cluster headache. This is a distinctive vascular syndrome characterized by intense headache attacks that occur in groups, hence we call them cluster headaches, often daily or weekly, then vanish for months or years. Average onset of age is 20 to 30. They occur more frequently in men than women, and they are believed to be a result of extracranial vasodilatation and increased cerebral blood flow a neurogenic inflammation affecting the vasculature of the cavernous sinus and its autonomic nerve supply. They are extremely painful, typically happen in the periorbital area and develop rapidly, reach maximal intensity within minutes. They typically occur 2 to 3 hours after going to sleep. They can occur several times per day and awake patients often from sleep. Associated symptoms include conjunctival injection, tearing, nasal congestion, rhinorrhea, sweating, partial Horner syndrome including meiosis, ptosis, sweating, and flushing. The carotid and cavernous vasculature is believed to be involved along with its autonomic innervation, the pterygopalatine ganglion and cervical sympathetic ganglion. Some attempts have been made to anesthetize these with lidocaine with limited success. Medical treatment includes abortive therapy such as sumatriptan. Inhaled high-dose oxygen is often very helpful. High-dose steroids and NSAIDs may be helpful. Prophylactic treatment includes beta blockers, calcium channel blockers, and tricyclic antidepressants. Chronic cluster headaches may be treated with lithium. OMT should be performed with considerations for the upper ribs, cervical and thoracic spine and associated soft tissues, and relevant craniofacial structures. Here's a picture of cluster headache. Lastly, let's discuss paroxysmal hemicrania. It's very similar to cluster headaches, although much more rare. They occur daily. They're unilateral attacks of pain which do not switch sides. They occur in the oculofrontal temporal region and location. They can last from 2 to 25 minutes, and they may occur 10 to 20 times per day. Next, let's discuss temporomandibular joint dysfunction. This is the most frequent source of facial pain after toothache, and 1 in 25 people are affected, females greater than males. The greatest incidence occurs in adults 20 to 40 years of age. Important etiologies include myofascial dysfunction and vasodilation, internal derangement of the jaw, degeneration of the articular surfaces, local trauma. It can be a physical manifestation of stress, or it may be the result of hypoplastic mandibular condyles. Myofascial dysfunction is the most common cause of TMJ pain. This can come from malocclusion, jaw clenching, bruxism, nail biting, gum chewing, stress, anxiety, OCD, or somatic dysfunction. Head trauma, whiplash, and strains of the upper cervical complex may cause this as well. Dental procedures have been implicated previously as well. Bottom line is that muscle hyperactivity and dysfunction lead to chronic pain and internal derangement and possibly degenerative changes of the jaw. Internal derangement of the TMJ is a biomechanical problem within the joint. Spasm of the muscles of mastication may be a response to the internal derangement as opposed to the cause. Anterior disc displacement is the most common symptom. This is accompanied with an opening click as the disc reduces, and a closing click as the disc redislocates. If the condyle cannot override the displaced disc, then jaw locking occurs. Patient complaints include facial pain, limitation in jaw range of motion, pain with chewing, crepitus, headaches and neck pain, as well as earaches. Jaw locking open or closed. Differential diagnosis for TMJ includes the following: dental infection, mandibular fracture, osteo or rheumatoid arthritis, trigeminal neuralgia, tension headaches, otitis media, sinusitis, or temporal arteritis. Treatment includes OMT, massage and myofascial release, heat or ice, mindfulness with eating, relaxation techniques, addressing postural decompensations, addressing bruxism. Medical management may include NSAIDs, muscle relaxants, tricyclics, or gabapentin. A dentist may be helpful in the treatment. Other lifestyle modifications including decreasing caffeine to minimize muscle spasm, decreasing the use of alcohol, and to address anxiety, depression, and OCD. In summary, TMJ dysfunction is pervasive and the evaluation can be complex. It is very important to note that TMJ is often self-limiting. Structural evaluation of the TMJ should include the muscles of mastication, alignment of the jaw, temporal, sphenoid, and occiput mechanics, cervical spine mechanics, and posture. With treatment, address the malalignment and mechanical problems early. Long-standing strain and dysfunction will lead to changes in disc morphology and osteoarthritis of the TMJ. This will make conservative treatment less successful. Thank you. We'll see you in lab.